questions or any comments you want to make, please.
So, hello. The case I want to show you today is the case of this 66-year-old man, very high cardiovascular risk factor, with polyvascular past history and coronary artery disease for 10 years, with multiple PCIs on the RCA and the LAD. And he presents symptoms of stable angina with a significant inferior ischemia. You can see the angiography. The problem is on the right coronary with this suboccluded ostium with a competitive flow from the left side. And if we zoom, we can guess this big calcified nodule, paraostial subocclusive, and also instant restenosis and the neodistal very calcified lesion. All the arteries very calcified. So I will focus on the calcified nodule because it remains a big challenge in PCI today, with high rate of stent failure, mainly due to stent under expansion, even if we use some dedicated calcified preparation tool. And one of the way to get good expansion now is combined strategies like atherectomy and acoustic shock wave. But now, with the LithiX, what did we learn? With the Pinnacle study, there were 9 calcified nodules on the 63 lesion, and very good results only using the LithiX, with 100% angiographic success, no complication, and over than 100% stent and expansion. And this is due to the earth contact principle, because the calcium has a very high module of elasticity, and the hemisphere will split clearly the nodule, as you can see on the intravascular coronary imaging. And the fact that the calcium is very high module of elasticity will amplify the force of the hemisphere and really split the nodule. And I had also some personal cases with a calcified nodule. This one I showed it a few months ago on a webinar, and it was a left main distal with a very big calcified nodule identified of IVUS. And I could treat it with one LithiX 3.5. You can see on the IVUS the deep fractures and the very good results. So that is my strategy for this nodule. Challenging case, I needed very big supports. So I chose the 7 French AL 0.75 right radial supports. The first step was to cross with CTO toolbox. I used the microcatheter and I could cross it with a Gladius CTO guide wire. And then I could start my LithiX strategy. So the first step recommended is to pre-dilate with a 2.0 balloon to achieve lumen. So you can really see the big stone on of the calcified nodule and the ostium. And I did it also with a 2.5 non-compliant balloon. The second step recommended is to use intravascular imaging or stent boost. In this case, I had already many informations about the calcium, and I chose to use the stent boost and multiplying incidence. And then it was easy to cross with the 3.5 millimeter LithiX balloon. And I did prolonged inflations. I did low then higher pressure. I did many inflations with smoothly changing the position of the balloon so the hemisphere can go on different ways. And you can see here, it's still a big waist, but it's lift a little bit. And then the fourth step recommended is to use systematically a non-compliant balloon then. So the fractures will go deeper. The LithiX initiates the fractures, and then the non-compliant balloon will go deeper. But there was still a waste. And what I found very interesting in this case, and I did it at first because I wanted to treat with the LithiX the other lesions more distal, that I alternated LithiX, non-compliant, then LithiX, then non-compliant 3 times. And then at the end, I could lift totally the print, the waist. And then you can see here, it was really easy to cross until the inferior genus with the LithiX, even if I inflated it 10 times on the calcified nodule. And I could treat also the other lesions with the LithiX. I had to use a guiding extension catheter to bring a drug elliptic balloon, while it wasn't necessary with the LithiX. So I treated it with a drug-coated balloon and in-stent restenosis and distal lesion, and the stent at the end on the nodule. And here you can see the final result that I found very satisfying. So in conclusion, on calcified nodules, earth contact principle enables good stent expansions with the few LithiX case we could see already. With a good crossability, I could do many inflations. It had a very good safety profile and very good effectiveness, even on this case of nodule. Thank you.
Thank you, Charlotte. I like the fact that you did not stick to, you kept changing between the LithiX and the non-compliant balloon. Sorry, before we go any further, with a show of hand, we have a question there. How many of you have used LithiX balloon? So we do have a few of them. And the rest of you, do you have it in your department? You haven't used it? Does anybody have it and still hasn't used it? My one hand. So there's other people still haven't used it. Okay, there's a question here, please. If you want to take the microphone, if you don't mind.
A very nice presentation. Could you comment LithiX in in-stent stenosis? Is it useful? Is it allowed to
Actually, for the while it says other tools, preparation calcium, it's off-label, but I know some people already used it with good results.
So
and
from the mechanism
it was the
works,
case,
right?
It was the case, yes.
Because it is contact to the calcium or the stent.
Not on a fresh stent, but in old stents, I think it's not a problem.
Also, I mean, just you have to be careful. If you think about the mechanism, takes us back to understanding how every equipment works. If the sphere comes against the stent strut, you're not going to have any effect, deep down in the artery. So we're still building the experience with this. I don't think we have it yet. Of course, as this is typical for all of us interventionists, you kind of go beyond the boundaries and try to test it in different places. It might work, it might not, we still don't know. Some other people have used it, it did work. But if you think about it, if the sphere comes against the stent strut, it might not work. Any other comments or questions? Yeah, please.
I think we have to say right now that all the experience we have, especially in the study and also in the registry, are not with instant in the lesion subset of in-stent restenosis. So we are trying to understand, but maybe we have someone in the panel who have some experience with that.
In terms of
in-stent
restenosis, no, I do not have tests. I think that in case of calcified neoatherosclerosis, the concept of having new material, stiff material inside the stent, probably it may work, but personally I do not test. If I may ask to Charlotte to clarify, because it could be easier, you state that you use a multiple inflation deflation. So can you clarify your way to use a balloon in terms of how many atmosphere for the first inflation, deflation, how many times you inflate the balloon, because it could be, I think, important for all of us to learn how to use it at the best.
Yeah, it's a key of the LithiX using. I think it's really the concept of the calcium plastic, and where you really have to take your time to work the calcium. I don't believe very high pressure are the most important. I start with low pressure. The nominal is low, like 8, but then you can inflate more pressure. But the most important for me is to do prolonged inflations and multiple the inflations, so the hemispheres will move a little bit, and you multiple the first breaks.
Yeah.
And then the non-compliant balloon association is very effective, as you could see here.
Perhaps if I can add, we had 5 patients in my IVL with ISR, but they were all new atherosclerosis. But having said that, I think my colleague had 2 patients with fairly recent, it's not new atherosclerosis, calcium outside, and he used it and it worked. So I think if it does work, it means that it's probably maybe the hemispheres is in between the stent struts. I don't know, we don't know what it means, but it seemed to work. But again, it's very preliminary data.
Yeah, I mean, this is the whole point about this, because this is a new device. You start using it in where it hasn't been tested, it doesn't work, so it's the device. But this is why you have to understand. So step by step, I think we're learning about it a lot and becoming more familiar with it, and then in-stent restenosis will come after. Now, whether you could use it in freshly implanted stent, which in theory you should not have under expanded stent anyway, nonetheless, it is early stage, so you don't want to be venturing to areas where it's not recommended yet, and the balloon doesn't work. So one step at a time. And yes, again, important, so I'll come to you in a second. Important thing is the nominal is 5. You start with this, give it a little bit of time. You have to be patient. Of course, we're all very patient, aren't we, when doing the procedure? So you have to be patient. You have to do multiple inflation. If it doesn't work, you can increase the pressure up to 8, 12, which is the nominal. And some occasion, you could go higher. I'm not recommended this yet. You'll build your experience with it, but just take your time and learn about it. And of course, the stent boost is fantastic. I'm sure we'll see some of these images where you could see the balloon expansion. You could see it very well with the stent boost. And I'm sure we have some cases like this. There's a question here.
I was just going to ask about the height of that because like for cutting the about 129 micron for the atherotome. That was my first question. And second, whether any one of you experts have actually had a case where one of these hemispheres has come undone, disappeared when you take the balloon out.
Our answer to this, no one, and have been many bench model tests and animal model, and that nothing happened. Back to the first question. So we're back to the first answer and the differentiation we were trying to make. Of course, this device, the presence of hemispheres, is completely different concept what you're talking about, the atherotome. So it protrudes, this hemisphere protrudes 0.25 millimeter from the balloon. But the point is that we have to go one-to-one sizing, vessel to artery ratio. But when we have a healthy vessel, this healthy vessel will accommodate the 0.25. So there won't be any physical phenomenon taking place, so it won't damage the healthy vessel. On the other side, when we have a calcified lesion, this hemisphere will create the phenomenon and will create the energy which will propagate.
I think the clue is in the name. It's a contact. If you don't have contact with the calcium and the vessel wall, it's not going to work. Thank you very much, Charlotte. We need to get on here. And I'll invite Dr. Vincent Cork to present his case. Thank you.
Can I have my slides, please? Good afternoon, ladies and gentlemen. It's my privilege to share with you an interesting case. Whenever we are coming up with new technology, I think there are always believers and haters. This is just another NC balloon. This is a 57-year-old man, calcium score for 2,000, engineer. We fixed the RC in the usual manner with NC balloon and DES. We thought we could do it in the same manner for the lap circumflex. As you could see, this is the pullback of IBIS showing different morphologies of calcium. We have eccentric, concentric, calcification, and probably an eruptive calcified nodule with a sharp edge right at the mid-left circumflex. It's a concentric napkin ring appearance when we inflate the balloon. So we went on with the NC balloon, but we ruptured 2 times at only 10 hemispheres. So it's not just the napkin ring that ruptured the balloon. There are many mechanisms of balloon rupture. We can have sharp edges. We can have a poorly prepared balloon. But in this case, it's only 10 hemispheres. I think this the sharp calcified nodule that punctured the balloon. And we thought about alternative, all right? We did have used this shockwave before, and we did have complication with ruptured shockwave balloon during the delivery of energy. As you would know, the barotrauma is not just a 6 to 8 hemisphere you inflate the balloon, but it's equivalent to 50 hemispheres. So the hydraulic force can cause a spiral dissection, especially we have pre-dilated the mid and distal segment with NC balloon. A thoracotomy, we all know the limitations. We might have to upsize the rotoblader burr. We have to bias the guide wire. We have to exchange guide wire. So what else can we choose? So we tried the LithiX, all right? It works well, nicely, and we inflate the balloon gently, 1:1 balloon artery ratio up to 8 hemispheres, no rupture, and very good yielding of the napkin ring. And we suppose the first contact point of the calcium spike is probably the hemisphere. And we obtain reasonable cracking of the calcium at different levels on intravascular ultrasound. It's pretty much a controlled dissection. And we went on further with aggressive dilatation up to 12 hemispheres, which makes the balloon over a quarter size. And this is the final angiogram, final IVUS with a pretty good sand expansion with the bioadapter in the mid and the long DES in the distal left circumflex with an optimal sand expansion. Rototripsy is a very attractive option when you have an ultra calcified lesion with uncrossable stenosis. All right, this is the very nasty calcified lesion in 80-year-old present with NSTEMI, and you could appreciate that there is a dense calcification everywhere. And the deep calcification, of course, the microcatheter couldn't cross, no balloon could cross, and we perform a rotoblader up front with bare wire of the rotor wire. And the sand boost is very useful when we use the LithiX, and we could identify the lesion, whether the balloon is well expanded. We use the same balloon in the distal and the proximal, and inflate it into higher pressure in the proximal segment, make it quarter size. This is the final angiogram. It's IVUS guided angioplasty, and we blow up the proximal lesion up to 3.5. So the take-home message is the LithiX provides an excellent, user-friendly, and safe option for calcium modification. We have a lot of things in our toolbox nowadays, especially for crossable but undilatable lesions and lesions with sharp calcium spikes, in particular when we rupture several balloons. And it has a good crossing and recrossing profile compared with cutting balloon and shockwave balloon. And multiple inflations and repositioning create new points of contact for hemisphere, generating calcium fractures with various morphology, in particular nodular calcification, which may require 8 to 10 or even more inflations. Thank you very much for your attention.
First question I have, great case, excellent case. Do you see any difference between the impact of this device on concentric and eccentric lesions?
I think, well, it works well in different types of calcium morphology, all right, with the, the concept behind. And I think we used the shockwave balloon since 2019. In fact, I reported the first couple of cases of ventricular capture. And we find that the shockwave balloon is most useful in concentric calcification. For eccentric or nodular calcification, sometimes you have to use up all the cycles of, IVL. But for this one, we can use it repeatedly, up to 10 to 14 inflations without issues. So I think, and also the same balloon can be used in the proximal and distal lesion. As you can imagine, many a time we have a different calcium morphology within the whole length of the vessel. So you don't have to use different, tools for the same vessel.
Thank you. Any comments or any questions, please?
I had another question. I'm trying to wrap my head around how this technology will work when you have, say, a 120-degree calcium and relatively healthy contralateral wall. That picture that you showed with the stent boost, it clearly showed your wire to one side of the balloon. And it looked quite eccentric there, which is the proof of the fact that if you've got calcium on one side of the vessel, not the other side, it may not actually be as effective. How have you found this balloon to work when you don't have a concentric region, as you said?
But you have, we advocate the different positioning of the balloon, all right? So you move it ups and downs and using different directions. Hopefully, the spheres will get into contact with different areas of the calcified nodule or fragments. So to achieve a controlled dissection of the and get a good lumen gain.
Yeah, I mean, it's a legitimate question, absolutely. But you have to remember it's only a low pressure. So the concentration of the pressure will be at the spheres, which I think Galia will show you right now, because that's where the most pressure applies. In the soft tissue, it doesn't cause any problems. It's all the pressure will goes into the spheres, into the calcium, even in eccentric one.
So you need to have, that's why the one-to-one sizing, because you need to have anyhow contact here with this hemisphere and the calcium. But on this part, you won't have any phenomenon taking place. Only here you have. Of course, I mean, it's easier to understand how it works here because of the propagation of the energy. But the phenomenon is taking place only here, where you have contact between the hemispheres and the calcium. And then it will propagate to all these calcified lesions. So what you see, absolutely correct, but we use it to assess indeed that we broke in the mid of the balloon. So we want the balloon to expand on both sides, but this is not something we have to check with the LithiX. After the first LithiX use, we have to go then with a non-compliant balloon, access for good expansion, or as the colleague Charlotte showed, multiple inflation, and then you will get to the point.
And I understand this gentleman's concept because, when you inflate the balloon, you have one side is elastic. All the force goes to the other side, right? Sometimes we have to go off-label and inflate the balloon higher, at higher pressure, maybe up to 18 atmosphere, all right, in order to get the stress directed towards the eccentric calcium.
Thank you very much. In the interest of time, we need to go on. Thank you for your really clear presentation. Now we have Dr. Enrico Sirato will show us another case, and we could discuss a little further before the end.
Okay.
Fine, thank you.
Okay, good afternoon again. This is my case. Basically, is a 75-year-old male with some risk factors and have a previous PCI on LID with desimplantation. We know that is a calcified vessel, was treated using a cutting balloon in this setting. Have again a crescendo angina and a positive ergot stress, so we was scheduled again for an angiography. The result on LID was remarkable. And we assess this PDA distal lesion, focal lesion. But the point is this obtuse marginal calcified stenosis of this branch in a codominant circumflex. So no, it was not so easy as it seems to wire, maybe because there is a double bending to reach the vessel, and there is also calcification in the ostium. So I succeed using a right radial procedure, a number standard support with extra backup. But I need to use an angulated microcatheter and a Sion blue to correctly wire the lumen. So I start to use this kind of strategy. I cross with a 1.5 semi-compliant balloon. I confirm that the lesion was crossable, but as you can see, there is no expansion of the 1.5 and in the proximal and in the distal part. So I tried with to apply more force, like with moving on with the NC balloon, short NC balloon, but we tried different trademark of balloon, different lengths with low atmosphere, but as you can see here in the phrase, there is eruptors in 2 times of that balloon. So I confirm again that the lesion was not dilatable, and so at this point we have to choose your strategy. Probably in the past you have to move to some atherectomy to end up the procedure, but you know there is some concern also about the bending, about to use rotablator in that setting. So I would like to test LithiX. This is the result of the vessel after the 2 millimeter ruptures. Fortunately, there is no damage, no slow flow. So I use LithiX as a shorter one, and the later one is a 2.014. There is a unique length. This is the angio that I store live about the crossing. As you can see, there is a kind of force that I have to apply, but I can cross the lesion. And then I start, as we mentioned, low atmosphere. In that case, for me, the vessel is not 2.0. Clearly, it's a 2.5 at least. But I use the smaller one because I would like to cross. It's a nearly uncrossable lesion. As you can see, start applying the first with a stent boost. You can observe some changing. And again, this is an inflation at 12 atmosphere. And as you can see here, there is an eccentric expansion, but we obtain some gain. We do not have ruptures of our balloon, so we succeed in getting some space. At this point, you have to move to NC balloon, as we mentioned, because we would like to optimize our result. We would like to have a ratio of 1:1 or to our vessel to make the potential, the crack into to have the maximum expansion of the vessel. And at this point, we can use at high atmosphere because the risk of ruptures probably is low. At this point, I was able to open and cross with Ivor. I do not try at the beginning because I for sure was not possible. But as you can see here, we obtained some modification of the vessel with LithiX and NC balloon. We see fractures. It was also useful imaging, I think, in that setting because it's an ostial lesion. So I would like to assess also the presence or not of dissection of the ostial part to decide the strategy to treat such patient. In this particular case, I decide to deliver a DC balloon, a sirolimus drug-eluting balloon, 3/430, from the ostium to the marginal in order not to jail the codominant circ. As you can see on the right, the patient was scheduled again to treat the distal right, and we have this 3 months follow-up of the result using only DCB. Also, for the high bleeding risk of the patient, we prefer to limit the implantation of stent, and we treat again the right distal with DCB. So in my view, I can test the 2.0 balloon in some situation. It's we have to recognize this is a novel thing because it's the first balloon with this size that we have with potentially use of intravascular lithotripsy with this side. With this some kind of situations that maybe you can use it, expand our approach, like small vessel, side branch, distal lesion, or tortuosis, in which even expert operator maybe have some concern or use a rotablator. The step-up approach, I think, has to be used. I mean that you have to be sure to deliver the balloon before opening it. So the strategy could be use 1.5 to use at least NC balloon to confirm that is not dilatable applying a non-compliant versus, and then you can deliver the LithiX and use the same protocol, maybe using a bigger balloon or using a 1-to-1 ratio to optimize the final result. So this is the settings, and just to summarize, which could be, I think, use this particular size of the balloon. And my conclusion is that the balloon could be useful in some kind of situation to increase utilization of balloon-based calcium debulking technique. We have to be ready to adopt a stepwise approach. We cannot decide to go up front in that situation with this kind of balloon. DCB could be a good solution for this patient. In the future perspective, we know that probably shorter balloon or another 1.5 size of this balloon could help in also extend the possibility of using this technology in early uncrossable lesions. Thank you very much.
Thank you. Any comments from the panel?
I just wonder if you, it's a great case, and I just wonder if you force the LithiX balloon 2.0 across the lesion or just touching the lesion, but it got trapped or stuck.
No,
would it be a possible complication?
I store the live fluoro motion. And as you can see, I have a regular 6 French radial approach. So this is a live crossing of the balloon, even in tortuosity. But for me, it's the first test of this balloon, and it works even in tortuosity. Maybe with a shorter balloon, it will be easier. With this 14 length balloon.
Okay. Any other comments or? Oh, thank you very much for the interesting case and for presenting this. We'll just go to the final.
Because if you force it in, you can't get it out. So the caution in using small. Good case.
Right. So you have seen that this is a new technology. I'm not going to stand here and tell you this is the answer to everything. And as I said, you have to be pragmatic and you have to apply your judgment on what you see. The point about this, so far we're building good experience with it and seeing that it's effective in multiple situations. I mentioned before rotablation, orbital atherectomy require a special wire. IVL require the source of energy, and of course it has a limited number of... so this is a balloon that we use on a day-to-day basis, and very simple, very easy. We're still learning our trade. We're still finding out where it is effective, where it's not. I would invite you and encourage you really to try it, because you could only learn about it by trying it and learning from it. You understand the mechanism, you understand how it works, and you'll find out that it is very effective and very helpful in your day-to-day. So just to re-emphasize the point, understanding the mechanism, you have to assess if the balloon is not deliverable. And something we haven't mentioned, the smaller balloons has 3 rows of 7 hemispheres. The bigger one have 5 rows. So the 3.5 has 5 rows of this. So there's a little bit more pressure, if you like. So if the balloon is not deliverable, you could predilate and deliver the balloon. Of course, intravascular imaging always helps you to decide what you want. And be patient. You size 1-to-1. You take your time. In theory, you should inflate 1 atmosphere per second. And the nominal is 5 atmospheres. You leave it there. Take your time, 10, 15 seconds. If it doesn't work, you could deflate and change the balloon. So the contact will change, and you will be able to apply more pressure in the calcium. You could go to higher pressure, the nominal being 12. Don't forget, this is a semi-compliant balloon, so it can grow. The 3.5 could go up to 3.9, I think, or up to close to very 4. So just be careful with this. Be patient. Apply it more than once. And once you've done that, you could use a non-compliant balloon to expand the artery and make sure that you have achieved what you want to achieve. And we have used it, as you've seen, and all of us building our experience, and we're learning more and more about this, and we find it really helpful. It might not work, but that's normal, because laser doesn't work everywhere, cutting balloon doesn't work everywhere. So it is about learning, and the ease of use and the multiple use and the wire down there makes it very attractive proposition. It simplifies the procedure, as we said, no special wires, no special devices, and so on, and it allows you to achieve a good outcome. So we have seen some, and I think Valeria was part of some of these studies, as well as Dr. Rosley. Very encouraging result, and again, we're building our experience slowly, and we're using it in multiple cases. And so far, maybe by next year, you'll see multiple better results and even be encouraged. And hopefully, most of you would have tried it and found out that it is helpful. But my advice to you is always really follow what's recommended. We are, I said, we are patient. We are not. You take them, or just give it to me, and you start doing it as if it is a normal balloon. You have to follow how it needs to work, because when you understand the mechanism, it has to be slow. You have to do it the right way, because if it fails, usually we blame the balloon, we blame the equipment, rather than the operator cutting corners. So this is the most important bit. Follow how it should be used.